Good morning, everyone. I am going to start us with our land acknowledgement and celebrations and then turn things over to Erin Gonzalez, who will introduce our speaker this morning. We acknowledge that we are on the traditional land of the first people of Seattle, the Duwamish people, past and present, and honor with gratitude the land itself and the Duwamish tribe. This acknowledgement does not take the place of authentic relationships with Indigenous communities, but serves as just one way to honor the land we are on and resist cultural erasure. We also acknowledge that this country exists and prospered as a result of free, enslaved labor of Black people, and we honor the legacy of the African diaspora and Black life, knowledge, and skills that have been stolen due to violence and systemic oppression. We affirm our commitment to be aware of privilege and oppression and how they play a role in the lives of patients, families, and employees as we strive to be anti-racist and improve care for those with less privilege. And we have several celebrations this month, including Jewish American Heritage Month, Asian American and Pacific Islander Heritage Month, and Mental Health Awareness Month, which is really related to the topic that we're going to be talking about today, increasing access to the care that we all hope that everyone can access when it comes to our mental health and well-being. Oh, and just one quick reminder that we do have grand rounds next month when we're going to be hearing from our psychiatry fellows about their scholarly inquiry projects. So I will turn things over to Erin Gonzalez to introduce our speaker for today.
Hi, folks. I am delighted to introduce Dr. Angela Scott. She completed her doctoral training at Tennessee State University in Nashville, where she received clinical training at the Vanderbilt Kennedy Center and Monroe Carell Jr. Children's Hospital at Vanderbilt. She completed her predoctoral internship at Florida State University's Multidisciplinary Evaluation and Consulting Center in Tallahassee, followed by postdoc at the Kennedy Krieger Institute at Johns Hopkins in Maryland. Dr. Scott joined the medical staff at Cincinnati Children's Hospital Medical Center in 2016, and she's been working there as a clinical child and adolescent therapist and psychologist. She specializes in treating children and adolescents with a variety of mental health conditions, including anxiety, depression, OCD, ADHD, ODD, Tourette's, chronic pain, and general adjustment problems. In her current role as training manager of behavioral health within HealthVine at Cincinnati Children's Hospital Medical Center, she has been tasked with developing an innovative evidence-based training program, offering ongoing training and consultation support for the HealthVine care management and care coordination staff, as well as HealthVine's sub-delegate organizations and community partners. These teams work side by side to serve Ohio's most vulnerable youth presenting with complex medical and mental health needs. Dr. Scott is committed to community outreach and advocacy. She's partnered with various organizations in Cincinnati with a focus on increasing mental health awareness, reducing stigma, and improving access to quality mental health care, especially for underserved groups. I had the pleasure of getting to meet Dr. Scott at the SPAC Pediatric Psychology Conference 2 conferences ago, and really enjoyed hearing her tell us about everything she and her team have created. And looking forward to hearing the updates and to you all getting to hear about it today.
All right. Well, good morning, everyone. And thank you so much, Erin, for the very warm welcome and introduction. Really excited to be here with you all to really share some of the wonderful and innovative work that is taking place down at Cincinnati Children's. This is work that is very personal to me, not just as a psychologist, but also as someone who's very passionate about improving those systems that provide care for our most vulnerable youth and families. And so we're going to kind of walk through that. I'll tell you what we're going to cover for today. We're going to look at practice gaps and really, talk through why and how this programming came about in the first place. We're going to evaluate those comprehensive behavioral health training and consultation model that we've developed. I'll tell you about how this aligns with both our statewide initiatives and also with evidence-based practice. And then we're going to talk through outcomes. So we're going to talk about what we have accomplished so far, what we're seeing as far as some preliminary findings, and which I feel like are really encouraging. So we'll kind of walk through that together. So as many of you are well aware, we are in what is being termed a mental health crisis. We are in unprecedented times when it comes to the demand for pediatric behavioral health services. One of the things that really stands out to me, and one of the areas where, obviously I have been really making a goal for myself of having the greatest impact, is around workforce development and workforce shortages. But we're also dealing with, obviously, decreased access to care based on making sure that we have services, and not just services, but equitable and quality service in areas where kids live, so they can stay in their communities and receive that service and support. We're also seeing record high ED and inpatient admissions, and so we're working to try to mitigate that as well. And then also disparities in access to care. And so a lot of the programming that I'm going to talk about today is centered around trying to really adapt and respond to this kind of state of things, or state of being of things, as we see today, with regard to how we're doing with meeting the need and kind of closing those practice gaps. So getting upstream. So one of the primary objectives of Cincinnati Children's is to really try to get in front of, or get upstream as much as we can, of these potential crises. And so a lot of the work that you'll see is more so on the prevention side and on the mitigation side, as opposed to working alongside folks to, while also working alongside folks who are actively doing the work and addressing those concerns as they come up. But we're really wanting to get upstream as much as we can to prevent potential crises, ED admissions, and things like that. And so we have developed a population behavioral health strategy. This strategy involves all of population health. And so, like I said, today we're going to focus more on the workforce development piece, but just to kind of give you a sense of what the overarching strategy looks like. It is community-based, which means that we are collaborating with and we're connecting with providers in the community to help to elevate their work, to provide the skills, the training, and the tools to resource them so that they can best meet the need of the youth and families in their communities. This approach is data-driven, which means that we are collecting real-time data, and we have really great metrics, and we have experts on our teams who are able to give us real-time feedback as far as how our interventions are faring, and whether we need to adapt our approach. And so we're able to be really responsive when we notice system-wide issues or trends in the data that lets us know, hey, maybe we should try this, or maybe we should sunset that. We should try to, ramp up our efforts in this area. And so it's really great to have this data-driven approach, because it helps to support, like I said, in the moment, real-time change. And then when we look at this approach, it's also payer agnostic. And so a big push of the institution is around helping to provide support for folks, regardless of what your insurance is, that you have the same level of access to the same quality of care and the same types of services that the entire population is going to be privy to. And so really just creating that equitable care there. And then that kind of links up to, or connects really well with, the next component, which is being access focused. And so we just want to make sure that, youth are able to get equitable delivery of care, but we want to make sure that kids are getting the care that they need, that every child has access to it, but that they're getting to the right level of care. Oftentimes what we find is that when there's a mismatch between both the providers or the, whoever the mental health professional's experience level is, and those referrals that get made, sometimes we find a mismatch between level of care and the presenting concerns. And so just providing that training and education and support to help to bolster their confidence and knowledge in the area, so that we're getting kids to the right place at the right timing, and we can avoid those delays in care, or repeated episodes of care and things like that. So we're really working, like I said, to get in front of this issue. And there are many kind of moving parts when it comes to the Office of Population Health at Children's. And so, like I said, the part that I'm going to more so focus on today is the workforce development piece, but each of these components has a specific kind of like entity that is working to kind of address these different issues or concerns within the Office of Population Health. So to give you more of a focus in on just the training and consultation piece and the workforce development piece, we've developed a model of training and consultation, which we have found has been really effective in ensuring not just the effectiveness of the programming, but also the sustainability of that programming as well. And so these are kind of those core components that we've identified as being necessary for programming to really be effective. So content experts as leaders. This is really important because we want the folks who have the expertise in the areas that we are going to be amplifying with regard to the types of care that our care managers, our care coordinators, our providers, and whoever it is that we're training. We want to make sure that we have experts providing that training and that consultation support, not just even in the areas of training based on their behavioral health needs or mental health, but we're also looking at training in the areas or having experts in the areas of data analysis, right? Like we want the best data analysts, and we want folks who are able to provide their level of expertise to help push this work forward. And so even with the development of the program that I'm going to discuss today that we've developed for our group of care managers and care coordinators, one of the biggest focuses on, even prior to me stepping into my role as training manager, was to make sure that they were selecting the right person for the job. And so there was a lot that went into the creation of my position, but also the recruitment process for the position, and not just for myself, but also for everyone else who is going to be on the team and contributing to this work. The second piece was institutional commitment. I feel like that's probably one of the biggest factors when you think about whether a program is going to be successful and going to have longevity. One of the things that we have been able to really garner at Cincinnati Children's is a lot of support for this programming, and so not just financial support, but also with acknowledging the program and making sure that we're getting the level of recognition that's needed to help us to continue to further our initiatives and our efforts. And so institutional commitment, very important. Intentionality in the hiring and onboarding, I kind of discussed that a little bit earlier when we talk about hiring content experts as leaders. There was a lot of thought and consideration put into, who is going to be the right people for the jobs that we need in order to keep this program moving forward. And so the interview process, I probably met everybody in Healthvine as I'm, interviewing for this role, but also everyone else met everyone too, right? And so there was a shared vision or this sense of shared perspective when it came to what is the expectation, what are we hoping to achieve, and what is the vision. And so that was so critical to ensuring the success of the program. It's a data-driven approach, much like I talked about before, so having that real-time feedback where we can be responsive and adapt and grow. And then, of course, ongoing training and case consultation. And we'll talk about this piece here in a minute and how important that is when we think about trying to close practice gaps and educational gaps for our providers and other folks in the community who are providing these services to the youth and families that we serve. But really moving away from the, kind of typical model of, let's get our, we get licensed, so we go through, this kind of intensive training, and then we maintain our licensure via CEs and things like that. But really, this approach is more so ongoing training and consultation. And so as I describe our program later, you'll see how our care managers and care coordinators are in consistent contact with and in consistent engagement with the training program. And this is a system or a model that's being implemented across the care continuum. And so you'll notice that even from, if we look at level 0, which is we consider to be more of those home-based services or community health initiatives, we are working with folks who are providing those services to get the training and education support in those areas, all the way up to our inpatient and residential programs. They're all being exposed to this particular model of training. And it looks a little different, based on, the population that you're training. And and so we can really adapt the programming to fit their needs. But for the most part, the overarching model is really the same as we look at how it's applied across the care continuum. And it's really, I think, significant when we think about our care managers and care coordinators, because they're going to be present at most of these different levels of care, right? So we're going to see them in the, inpatient, we're going to see them in outpatient settings, we're going to see them, across this continuum. And so by, implementing the training program that we have, we're able to affect change, not just within, the realm of HealthVine, but also across the institution and across the continuum of care. So just to kind of give you an example of one learning network that has been implemented just since my time as starting in my role, it's the PINK network, or the Pediatric Improvement Network for Quality. This is a learning network that has been developed to help to support those providers who are in primary care and obviously behavioral health. The work is very centered on, screening. So again, we're trying to get upstream. We want to try to identify and provide early intervention as soon as we can, prevention, of course, and then implementing evidence-based care. And so a lot of the training and support that's provided to all of these organizations is around helping to really get evidence-based practice implemented in a way that's consistent enough that we start to impact outcomes. So where we're seeing, people are getting better sooner. We're seeing that, there's shorter duration of treatment. And so we can increase access in that way, because we have folks who are able to get into, see their provider without extensive wait times and things like that. And so the PINK Network has, kind of launched and is more so focused on the community as far as primary care and behavioral health providers and things like that. We also have our IBH program, which is not pictured here, but integrated behavioral health is another area where we are training and working with those providers who are embedded in pediatricians' offices, who are, providing that support for youth and families in those settings. And so a lot of, like I said, there's a lot of attempt to spread this model so that we're getting the most impact and hopefully able to impact overall outcome for the population of youth that Cincinnati and the state of Ohio is responsible for. But just to kind of give you a glimpse of kind of where we're standing. So I mentioned before that, our traditional model of training is really, you finish your formal education, you go through your intensive training programs, and then you kind of sustain your education, or you kind of maintain your licensure by attending workshops, conferences, you do your CEs, we're making sure we're keeping up with what the requirements are of our state boards. And then of course the learning in a lot of ways can be self-directed. So you can read and research and learn on your own. You can also do some practical experiences. So many of us learn on the job. You can, get exposure to, different roles or areas and areas of specialty and things like that. So we can learn on the job. And then of course through professional networking. So we're engaging with peers and experts in the field, and we can learn that way. So that's more of when you think about continuing professional development. And really this is consistent with when we look at how our care managers and care coordinators are trained and educated. This really is kind of the model of what we see happening in that area. And then, of course, there are peer learning networks, which kind of extend this a little bit more. So you have folks who are engaged in maybe some shared planning, so they're collaborating on projects and initiatives together. You may find that folks are doing some peer observation, so they can, observe and look at other folks' work to really borrow from that and bring back to implement within their own programs. You see this collaborative work scrutiny where, you're reviewing cases together. A lot of times, one of the key things that I found with one of the teams that I support within HealthVine is that their care management teams, they do like a yearly case presentation. And so each person is responsible for at least once a year presenting a case. And so they're able to provide feedback for each other in that way. But if you think about it, that one person's opportunity to present a case is like once a year because there, obviously there's many of them. And so with the rotation and the way that it works, they really only get that one opportunity to engage in that training activity. And while they do have exposure to, other folks presenting and kind of having that experience, the experience of actually presenting a case and putting that together and using that conceptualization to provide that information to a team of folks who are going to, then scrutinize that work. It is, you get that one opportunity. And so really a goal of our programming is to try to help to create more opportunities for these kinds of things to happen where it's not just a one-shot deal. We're not, checking a box and saying, hey, we've met our competency level with this, and so we can say that we've satisfied that requirement, right? This is ongoing training and education and consultation support. So unique features of the BH training program and really how it differs. One, we have a targeted population. So we are specifically, at least the program that I'm going to talk about today, my kind of neck of the woods, is the training program for our care managers and care coordinators within HealthVine. This program is specifically developed and tailored to meet the needs of the teams within HealthVine. It's an innovative approach because what we're doing is taking this kind of larger population health model and this larger training and consultation model, and we're kind of whittling it in, and we're really creating this unique way that we're implementing it with this particular team of folks. And you have to think about their work is a little bit different than a typical provider's work would be, right? Like if you look at a physician or a psychologist or other mental health, therapist or provider, you're going to see that they're more in that direct clinical care for patients. Whereas our care managers and care coordinators, while we consider that to be direct care. One of the things is that they're kind of coordinating all of that. They're kind of managing all of those things. And so we've really found an innovative approach to help to support uniquely this group that if you look at traditionally the types of training that these groups get, it doesn't specifically address like the mental health or behavioral health piece in the training in the way that, it's highlighted enough that when they are out here working, and supporting, families who are presenting with complex behavioral health concerns, that they have the skills and the knowledge to be able to do that. And so we're really working to increase and elevate the level of exposure to this, to these, content areas so that they have the tools they need to be successful. Also, again, ongoing education, skills-based practice. A lot of what we do is a lot of hands-on interaction with the content. So not so much just sitting and listening to a lecture, but more so being able to engage in some case examples, being able to do some role playing and things like that. And then we try to align as much as we can with statewide initiatives. So if many of you, I don't know if you're familiar with Ohio Rise. Ohio Rise is a program that the State Department of Medicaid has developed to help to address more so those needs of the youth who are presenting with really complex behavioral health concerns. And so there's, separate funding set aside to help to really support those youth. But we have an entire team within HealthVine that supports those youth who are Ohio Rise eligible. And so a lot of what we try to do is align our training program with the statewide initiatives as far as what the state requires for their training, what they need to make sure that they're compliant, and also what the initiatives are for the state. So if the initiative is we want to increase engagement, we want to lower ED rates, we want to increase access, et cetera, we can tailor our training and we can tailor our approach to our programming in a way that helps to align with those statewide initiatives. And so we've been doing that across the board, not just with our Ohio Rise teams, but with our HealthVine CM teams as well, who are providing more for like CareSource and other MCOs. All right, so now we'll kind of get into it. So we'll talk a little bit about the program and how it's structured, what it looks like, and how we have kind of implemented this over time. So to give you a little background information on HealthVine, so HealthVine is a Cincinnati Children's Accountable Care Organization, or ACO. We have delegated responsibility for about 115,000 youth that are in the Southwest Ohio area. Now, these are Medicaid only, so HealthVine serves patients who are Medicaid eligible only. So it'll either be Ohio Rise Medicaid eligible, or for our folks who are more CareSource and other Humana, et cetera. We have Cincinnati Children's has delegated responsibility for more than 115,000 youth, but when we think about specifically this component, we're looking at about 115,000 that we're responsible for. And really the mission of HealthVine is to try to integrate as much as we can care management across both the physical and behavioral health needs of the youth. And so we're not just, sometimes we can be so siloed and pocketed in the way that we're providing that support, but we're working to train and to make sure that our teams have the tools that they can work with both, right? If a youth is presenting with a complex physical need, they can also support them with regard to their behavioral health needs. Now we do, like I said, when we think about youth who are more Ohio Rise eligible, they're going to be we're going to be looking at more complex behavioral health needs. And so typically what we'll find is that if a youth is being seen by one of our other care managers, which they manage both the physical health needs and some of those lower to moderate, mental health needs, we may refer them over to Ohio Rise just if the needs become significant enough that we're going to need to support them at that much higher level of care coordination for the behavioral health needs. But really this program was initially developed for a subset of care managers, like I said, at the Ohio high-rise programming was something that actually launched at the same time that I started in my position with the training program. And so we were kind of building the plane while we were flying it, trying to adapt to the statewide initiatives and mandates, and trying to make sure that we're in alignment with everything that the teams needed, both for our teams who were existing and providing this care management support, but also for our new Ohio Rise team, which was really just trying to get their footing and operating both as a an accountable care organization for other CMEs in the area and everything. So it was definitely, I feel like, a hit the ground running approach to getting this programming off the ground, but it was so meaningful because we were able to really tailor our approach to meet exactly what the teams needed, and we're able to grow with the teams and adapt with the changing statewide mandates and things like that. So the first thing that I kind of did coming into my role is I really wanted to learn what exactly is the role of our care managers and care coordinators. I really wanted to get a sense of what their scope of their role is, what's the scope of their area of responsibility, and how can I best support them in the work that they are doing. And so I actually went and shadowed and sat in on some phone calls and care team meetings and just their overall meetings and huddle meetings and all of that, and really just got a sense of, what does this work look like on a day-to-day basis, and what does this, in what ways can I fill some gaps for them? And so that was a really big learning process. We had a lot of collaboration from our Healthline leadership teams, and just helping to facilitate my entry into this world of care management and care coordination. I'm a psychologist by training, and so my world looks a little bit different, based on my approach to how I would, evaluate and assess care needs for a family, or how I would develop and implement a treatment plan and things like that. And so we were really trying to find common language and find, some areas where I know that we could have impact. And so a lot of the first part of my role was just getting a sense of, what exactly do these care managers do on a daily basis, and how can I best support them? But just to give you a little information on our team. So we have a team now. Our team has grown. I think when I presented this back at SPAC, we were at about a little over 100 members. We're up to 207 now. And we have a variety of disciplines that are working within the area of care management and care coordination. So nursing backgrounds, community health workers, clinical counseling, social work. So we have this kind of, hodgepodge of disciplines. And so that was also, I think, at the beginning, a journey that we had to go on, was really understanding from each discipline's perspective, one, what has been their exposure based on their training and their formal education, what's been their exposure level to the world of mental health, how can we best, kind of meet those needs, and really trying to do some level setting as far as, where is everyone on that, spectrum of, expert to novice, right? And so we really were working to develop some standardized ways that we could train this very diverse group of folks. And when I say diverse, I mean not just diverse in discipline, but diverse in a lot of ways. Our teams are diverse with regard to race and ethnicity, with regard to gender identity. And so we really have been working to make sure that we're trying to tailor our support as much as we can to address this entire population. And so our primary goals or objectives, when it came to our team member outcomes, so for our care managers and care coordinators, really the two biggest goals are to increase their knowledge and confidence, and we want to decrease burnout. We do know with the population of youth that our care managers and care coordinators support, this can be really complex work, and it can be really stressful, especially when you look at some of the situations or needs of the families that we serve. We have some folks who are dealing with issues of poverty, potentially housing insecurities, food insecurities. Some of the youth that we support have a history of trauma and abuse and, a lot of those things. And so this can be really taxing work. And when we look at, again, going back and trying to gauge, what is this person's exposure, background, training in the area of mental and behavioral health? How do we best support folks who may not have as much exposure in working with patients who have experienced trauma, or, trying to prevent re-traumatization, or trying to help to support the care manager from experiencing, secondary trauma and things like that for themselves. And so a big push has been to decrease, the potential for burnout, and to provide a lot of supports to help with the emotional well-being of our families alongside, or with our care managers alongside increasing their overall skills and their self-efficacy around doing the work. And then for patient or member outcomes, really two of the biggest goals: increase member engagement. When we think about the population that HealthVine serves on both sides, the Ohio Rise and the HealthVine care management teams, we are working with youth who can be stratified anywhere from what they consider to be like low risk or low acuity to very high risk patients. And so obviously the goal would be that we increase as much as we can the engagement with those high to moderate risk patients. And the reason for that is just simply because they tend to be a harder population to reach when it comes to keeping them consistently engaged with care. And so in order to prevent those, after 7-day, repeat admission to the ED and things like that, we're really working to try to help to keep them engaged with care management support so that they can get the support that they need without having to access those higher levels of care for like emergencies and crises and things like that. And then of course that then hopefully will result in reduced ED utilization, which is another big goal that we have. So to give you an overview of what the Universal Training Program looks like, so the program basically on a weekly basis, we're able to provide things like office hours. So I do office hours every day of the week, and I have different hours that focus on different aspects. So like Mondays and Wednesdays are content days, and so we focus on content that we've learned in our trainings. Tuesdays and Thursdays are open forum, meaning consultation. Folks can bring whatever cases that they have to the meeting and get support and consultation for that. I have our psychiatrist who is our consultant and who also works with me for my office hours and is able to provide support from that perspective as well. And so it's just a really great opportunity for folks to get access to me, but also to have access to our psychiatrist consulting, and then also to have an opportunity to get some really good skills acquisition, because during office hours folks have opportunities to practice. So we do role plays, we do case examples, we can just talk through, ask the questions that most people would be, I don't know if this is a stupid question. Should I ask this question, right? So it's an opportunity for folks to really engage with the cases that they have and to bring those concerns and things. And we can process cases from, both a biopsychosocial case conceptualization perspective all the way to how are you dealing with this case, right? Like how are you managing and coping with the stress of this case? And so it's just a really great opportunity for folks to connect with me and, our team, and to provide support in that way. The consultation piece, what we do is we provide care planning support, crisis and safety planning support. We also do PRTF application reviews, so for our youth who are going to potentially be needing residential care services, to just help to review those applications so that the care managers and care coordinators who are kind of putting these things together, they know the language and the wording to use, they know how to best describe and talk through what concerns the youth is having and how to best ensure that they were going to have the highest likelihood of admission if that's the goal, or to get the best care in that case. And so we really work with our teams around that as well. From the burnout mitigation perspective, we have a few different kind of things that we are doing to help to support the teams in that way. So we developed wellness debriefings, which are opportunities for the teams to connect with me. These are kind of on demand. They can schedule these anytime that they need. And this is on the heels typically of any type of, crisis situation or critical incident. So maybe they had a, negative exchange with a care or with a member or a youth or family, or, something happened where maybe recently we actually had a situation where one of the youth that we were supporting committed suicide, and so, or died by suicide. And so one of the things that we worked with around the team was anybody who was kind of engaged with or involved in that case was able to come in. We could do the wellness debriefings and get some support in that way. We also provide office hours that are specifically dedicated to burnout mitigation. So Fridays are burnout mitigation days, and so folks are able to join and just kind of bring their concerns, and it's really a great safe space for folks to just kind of talk through some of the stresses of the job. And then we also just as an as an entity, we really try to, as much as we can, promote self-care. And so there really is this great culture of self-care within Healthvine, and all the way from our, top leadership down, there is a high level of respect for and appreciation for folks who are able to speak to their need for self-care and speak to the need to try to, take steps to mitigate burnout. And so those conversations are never off the table. And so that's one big piece that we've been working through. And then, of course, there's the trainings, right? So the trainings themselves, we developed a curriculum of trainings. These are, right now there's about 12 kind of base core trainings that we offer, but this is continuing to grow as we, see we're trying to respond to the needs of the teams. The great thing about having this data-driven approach is it kind of helps us to identify like areas where we need to, kind of beef up our efforts with regard to how we're supporting via training, and also some areas where maybe we could, not maybe put as much time and effort and focus behind that because maybe they've got that piece down. We need to focus more on this area. So it really helps us to structure how we offer the curriculum and in what ways we're delivering that curriculum as well. And so basically our trainings are going to be typically 12 trainings throughout the year. These can be spaced out depending on, what the team's needs are. And so typically we'll have like a fall kind of run where we do 3 trainings in the fall. Those are usually in alignment with some statewide regulatory requirements for Medicaid and things like that they have to get in and to meet those requirements. And then once we head into the spring and heading into summer, we really start to focus in on doing more tailored training support. So our teams this year have the option of doing focus sessions. And these focus sessions are specific to their team. So like our Ohio Rise team has their focus sessions and our Healthvine care managers have their focus sessions. And the goal really is that they get to select, the trainings that they want. We offer on-demand training, and then also we have kind of a library of trainings that they're able to have access to. So if they don't want anything on the list of available trainings, they can suggest a topic or a content area, and we will provide it. One of the requests that we had this year was around IEP and 504 plans. A lot of times, our care managers aren't as well versed in, when it comes to connecting with the school around these things. And so that was an area where we really had some great impact because we were able to collaborate with school services within Children's to have them come and, support us in delivering this training so that they could get those tools to be able to help to support youth from that area as well. So like I said, a lot of what we're doing is trying to be as responsive as we can in meeting needs as they come up. And so you'll see that the curriculum may adapt a little bit, but they really break down around some really core content or kind of competency areas, which we'll look at here in a moment. So to give you a sense of the timeline to implementation of the program, so what I will kind of preface this by saying is, so the conceptualization of the training program, my position, all of that really took place much, it preceded me joining the team. Okay, I'm giving you the timeline from when I joined the team and forward. But really, the conceptualization, the leadership team within Healthvine and in population health were really conceptualizing what this could really be and creating the vision far ahead of when I joined the team. But my position was created specifically for this purpose, which was to develop this programming so that we could move it in the direction that obviously our leadership was looking at moving the program into. And so really to give you my timeline, so I joined the team in June, and so I was both onboarding and explaining the vision for the program at the same time. Like I said, I went through a pretty intensive recruitment process and interview process to get ready for this, and really it was a quick, kind of turnaround to get on the ground and get going with, once I really understood, okay, here's what we're trying to accomplish. Let me figure out the best way that I can, deliver this this training. And so what we did was June, that was mostly that. July, we started to really assess the team needs. So this is where I'm shadowing, I'm learning, I'm trying to get to know the teams and, what do you need? I'm meeting with the leadership teams. We developed a quality improvement committee and team for just specifically, what data metrics do we need? What do we need to collect? How do we do that in the best way? How do we develop this kind of responsive data approach? We were also meeting with we developed a training planning committee, which helps to support the development of the trainings, meaning that, we're looking at what content do we want to provide, what do we feel like is going to be the best way to provide that content, and then, we just kind of go to the drawing board and we create these things and get them going. By August, we are aligning, making sure that we're hitting all of our regulatory requirements so our teams can get both those needs met and the needs of the training program met in their work. We are working out the logistics. That was kind of a tricky point. We had to figure out how are we going to offer these trainings. We initially started, we were 100% virtual. With the way that we were offering the trainings, we found that engagement was not as high. And so this year we've actually been working toward we've done some hybrid kind of piloting that this year. And by June, we're going to be 100% in person. So that's been a shift that just over the last year or so, we've been able to really make just based on what we're observing and the data that we're getting from the teams. And so we're working on developing content. In September, we piloted a training. So I did a specific training around crisis prevention and with our Ohio Rise team, and just got a sense of what their needs were and how that went. And then I also at the same time launched office hours. And then by the time we got to October, we are launching the regular training season. So that curriculum of 12 trainings was rolled out at that time. Now I do want to also preface this. We are building the plane as we're flying it. And so all 12 curriculum trainings were not created at the time that we launched the season. They were planned, but were being developed along the way. And so we kind of launched the program, we got it underway, and kind of got that started. Now, as we get into around October 2023, this is when we launched the second component of the training program, which we've been piloting over the last year or so. So we're really piloting this cohort model of training. What we found is that, obviously we want to be able to provide this really great expansive training support and consultation support, this ongoing training and education for our teams. But what we were finding is that engagement is kind of hit or miss, right? It's like, oh, well, I was able to attend office hours here this week, but then there were a couple weeks where, I was busy and I wasn't able to attend. And, so we found that it was a little bit sporadic with how people were really, engaging with the training program. And so we thought through how can we best, use some similar models, right? Models that we know that are being used within PINK, that are being used within IBH. How can we kind of translate that into something that we can use for our care managers and care coordinators? And so we developed this cohort training pilot. And this training pilot basically, what we do is we select team members, and we really have the leadership do that. They kind of offer the opportunity to our team members to participate in this cohort. This is a 6-month commitment that our teams are making, and really what it is it's all of the training program, but kind of condensed into a 50-minute weekly meeting. And so we are able to do, in-person meetings. We do didactic education during those meetings. We will have some case-based learning, hands-on role plays. We also are able to kind of monitor and provide feedback with regard to how they're progressing through the cohorts. And then it's a really responsive approach. And so the great part about the cohorts is that they bring to me what they want to learn about, right? So it's not just me providing structured education and offering a curriculum, but they can come in and say, hey, I know we had talked about this during one of our last trainings, but can you really give us some more support in this area? We really like to learn more about, substance abuse, or we really like to learn more about, fetal alcohol. We really like to learn more about, these different areas. And so they bring me, their questions and their concerns, and we can create and develop very brief didactics to help to support their work. And so this cohort pilot, we've done one completed pilot so far. Our second pilot just wrapped up in earlier this month, actually. So we're still pulling through the data for the second cohort, but we're actually getting ready to launch in June. We're working on spreading this model, so we're going to launch 3 cohorts in June, which will cover most of our teams that we support. So just to kind of give you that sense of that is also some work that's being done in alignment with the universal training track. All right, so let's look at some outcomes. So one of the things that we wanted to do kind of starting out was really to figure out, okay, so we know we have something that has the potential to be really impactful. How do we best measure, how do we actually measure what we're doing, and how do we actually best create metrics that can really speak to the work that we're doing? And this is very much still under construction, if that makes sense. We are still, continuing to really hone in on what are those things that we want to know, how do we best measure that, and how do we collect this data in a way that is reliable? Because that has been, I think, one of our difficulties or challenges moving through this is just data collection has been a little bit spotty. But really, for our team members, we focused on kind of 3 different areas. We wanted to look at our team member outcomes, we want to look at patient outcomes, and we want to look at outcomes for the cohorts. For our team members, really what we developed are pre and post knowledge questions. And so before each training, they'll get, an email link that allows them to register for the training, but included in that registration is typically a case vignette where they'll have to read through a case and answer some questions that are relevant to the content that we're going to be training on. And so they'll do that before the training, and then right after the training, they'll get another, email link that has that same vignette in there with the same set of questions. And we're really just assessing like pre and post, how are they doing? Are we seeing any increase in overall knowledge based on their participation in the training? We're also assessing confidence. So we want to see from a self-efficacy perspective, do we find that they feel more, confident that they can actually do this work, that they can implement and apply these skills in the work that they're doing? And so knowledge and confidence are really the 2 team metrics that we're looking at. For patient outcome metrics, we're looking at engagement rates and ED utilization. Those are our 2 big metrics now. We're also trying to work on getting some data on different metrics, things like patient satisfaction, that kind of thing. But patient satisfaction data is collected at a different cadence than what we are typically wanting for our programming. So it's been a little bit hard to map that data onto what we're doing, but we're really working to look at what other patient outcome metrics that we can explore for our families. And then for the cohorts, actually, just this year, we didn't have these for the first cohort, but for the second cohort, we've developed a case presentation rubric. This rubric is something that the team members want. It kind of gives them more of a structure of like, what should be included in your case presentation, what areas do you need to touch on, but it also is an opportunity for them to get feedback on how they are doing with their case presentation. So I am not the only one who is, providing a score for these. Their peers are also providing feedback on these case presentation rubrics, and it also specifically ask about the different content areas that we're training on and that we really want to make sure that they have some competency in. We're doing pulse surveys. These pulse surveys are given out at different, kind of a different cadence depending on the size of the cohort. So once we get through a round of presentations, so each meeting, one person will present a case. And so at the end of that round of presentations, we'll do a pulse survey. The pulse survey more so looks at, how much are they actually applying the skills that they're learning to their interactions with youth and families. So it'll ask questions about, how many times or how many interactions do you feel like you've been able to, engage in or use trauma-informed, approaches or tools or resources. And so really what it does is ask to see, how much are you actually implementing this in your work? And so that was what we do with the pulse surveys. For the satisfaction survey, that's typically something that's just given at the end of the experience and just asked about overall satisfaction. What'd you think of the experience? Would you, do this experience again? That kind of thing. And then we are also tracking some patient outcomes for the cohorts with regard to their engagement rates and their ED utilization as well, to see if we can compare that against like the larger team to know if there's a difference between those in the cohort and those in the universal track. So when we look at some of our outcomes, what we're finding is that, knowledge and confidence has increased across all content areas that we've trained on. So if you see there on the graph there, you'll see trauma-informed care, person-centered care, motivational interviewing, cultural competency, clinical skill development, and burnout mitigation. Those are kind of the overarching areas. Now, under each of these areas are going to fall a few to multiple trainings that we've done in those areas. So you'll find that when we look at the overall increase in knowledge, we're noticing definitely that we're seeing those increases, right? We're seeing about a 50% increase in knowledge for trauma-informed care, about a 31% increase in confidence. One of the highest areas that we're really seeing increase in knowledge is around cultural competency. When we think about more of those trainings that are focused on diversity, equity, inclusion, we're really seeing some increase and some change in how folks are able to implement this and apply those skills to case vignettes and things like that. And so really across the board, we're seeing really great outcomes when it comes to the team and what they're learning and how they're applying this information. One of the things that I was really excited to see is when we break this down by education level. So we really wanted to see, because like I said, we have teams that are very diverse. They're coming from different disciplines, different backgrounds, different levels of experience and training and all of these things. So we really wanted to kind of get a sense of, okay, so for our folks who maybe have up to a bachelor's degree, what has been their, what are their gains, as opposed to someone who might have like a master's or above, what would be their gains with regard to knowledge and confidence. And what we're finding is that obviously one of the findings that we kind of expected was that, for folks who have, up to a bachelor's degree, that they're gaining a little bit more with regard to their overall knowledge and confidence. For our folks with masters and above, we're finding about a 41% increase in knowledge and about 29% increase in confidence overall. So, and then, like I said, this is across all content areas that we are that we're focused in on. When we look at that by experience level, so folks who have either just entered this world of care management, care coordination, or folks who are 6+ years in the game, what do those gains look like for them? What we're finding is that obviously for our folks who are newer, we're seeing increases across the board. But what was interesting is that for our folks who are kind of that 3 to 5 year range and then 6+ range, we're actually seeing increases in their knowledge that are a little bit higher than what we saw for our 0 to 2. And really the only thing that we can account for that is just that, if you're fresh out of your training, if you're, you kind of have the most up-to-date information and knowledge, based on your exposure level. So what we're expecting is that, when we think about continuous ongoing training and education, it really highlights the need to continue to stay on the forefront of doing this work, because even if you're 6+ years in the game, you still have something you can gain from engaging with this particular type of training. And so we're, like I said, really encouraging. We're seeing some outcomes that are really positive. And so we're really going to work to increase this even more as we move forward. But to give you a sense of how this is impacting patient outcomes, so this is a graphic that really just looks at from the time that the programming, we think about just that, I talked about how there was the original Health NCM team and then Ohio Rise joined us around 2022. But if you look at what the rates look like with regard to patient engagement for our high and moderate risk families from 2021 up till now, we've definitely seen some significant increases in overall engagement. And so I just kind of notated, where we are in those kind of benchmarks. So the training program launches in October 2022, and we start to see, that kind of gradual increase across seasons. And so definitely having some impact with regard to how patients and families are engaging and making sure that we're keeping families engaged with the care that they are receiving. When we think about engagement as well, to give you a sense of what numerically this looks like per season. So training season 1, we've got about a 17% increase in engagement. We're seeing a 33% increase in engagement since the last year, or for 2023, 2024. We are still in the current training season, so we're not quite wrapped up yet. But what we're seeing so far is about a 38% increase in engagement from our youth and families that we support. So really engagement has pretty much doubled since we started this programming. And we're seeing this consistent year-over-year growth with regard to how families are staying engaged with and utilizing their care management support. When we look at ED utilization, this is a metric that can be really sporadic depending on, what clinics, what patient population. Even our teams are very diverse in the patient population that they serve. We have some that are more focused on pregnancy, newborn. We have some that are more chronic, and we have some teams that focus specifically on, transitions of care and things like that. So this, you kind of have to take that into account as you look at the data. But really what we're seeing is that overall, our ED utilization rates are going down. We're seeing those decreases. And specifically, I wanted to look at and see, how's the cohort doing compared to our other team members with regard to their overall ED utilization rates. And we are seeing that overall, the cohorts tend to be averaging about 79 per 1,000, whereas our overarching non-cohort team is about 84 per 1,000, which overall is great because we're seeing utilization go down, but we're also seeing that for those who have engaged in the cohort experience, that their rates are even, declining at a much faster rate, I guess you would say, based on their having that unique experience. So like I said, really encouraging. We're really excited about the outcomes that we're seeing, and we're just really focusing in on now, just seeing how we can best, move this work forward and spread, so that we can make sure that all of our care managers and care coordinators have the opportunity to, engage with the cohorts, but also that they're staying engaged with the universal training track as well. And just to give you some of the feedback that we've received, this is, when we think about voice of the customer, this was one thing that was really a focus for us too, coming into the development of the programming, is because we really wanted to know, are we having impact, and what are people, what do people need? What are people saying about the training, and how can we best, again, be responsive to what to the feedback that we're receiving? And so, we've had a lot of great feedback. We've also had a lot of feedback that's helped us to kind of regroup and redefine how we're looking at things. I know one of the things I got for the cohort was that people felt like it was really repeated. They were like, "There's a lot of repeating. We learned this in the universal training track, and then we learn it in the cohort experience." And to me, I thought about that as, well, it means that you really learned it then, because if you notice that it was repeated from the training, but for me, that was encouraging. But for the team, I guess, so we're working on more ways to, different ways to learn and interact with that content. But that was feedback that we got. That was just someone who wrote that on a survey. They wrote it on the survey, and we were able to take that and really be responsive. So we enjoy getting that voice of the customer, because it helps us to really structure our program in a way that is meaningful. When we look at the case presentation rubric, so just to give you a sense of how it was set up, so on the rubric, the way that it was scored, you could get anywhere from a 1 to 5, 1 being not evident, meaning that their utilization or application of that skill was not evident, up to 5, which means that they had exemplary, evidence of that skill. And so when we think about where folks are starting kind of and where they ended, for the most part, people were averaging about 3s on their case presentation rubrics, which for us is developing skills. And then by the end of the 6-month experience, most folks were hitting that 4 mark, which is what we would consider to be or classify as proficient. And then on the pulse surveys, one thing that we found is that initially when we were doing the surveys, people were reporting a lot of, if you look at the understanding high-risk behaviors and safety planning, people were rating a lot of nevers and no opportunities. Like they were saying, well, no, we haven't had an opportunity to implement or use this skill with a family. We haven't had the opportunity. And so what we found is that, especially for the area of understanding poverty and the impact that it has on families, and really being able to be responsive in the way that we're providing care planning and resources, this was the area where we saw that most people were rating 5 or more responses, or 5 or more interactions, meaning that they were really able to implement this more often than any other kind of skill that we were learning or content area that we were studying. Now, understanding high-risk behaviors and safety planning, this was one where we did see it had the most never and no opportunity responses, and so this is definitely an area where we are going to be focusing in a lot on for the next training year, and just making sure that folks have the tools and resources that they need, because we know that this directly relates to ED admissions and all of those things. And so I think it was interesting that we saw that that they're rating, well, no, I haven't really had as many opportunities to do this, safety planning and understanding and implementing my knowledge around this area, given some of the acuity levels of the patients that we see. Now, I will say that the cohort that we're working with for the second round, these are mostly on the Healthline CM side, so they're more physical health concerns. So they'll see mild to moderate behavioral health needs, and so they may, just by virtue of the population, may not see as many of these cases. But that was, I think, an interesting finding that we're definitely going to explore more as we move forward. And then EDI or DEI was the other area, and this actually was an area that demonstrated the highest overall application for our teams. And so we were really excited to see that a lot of the training that we've been doing is having really strong impact in that area. But again, cohort feedback, we really, at the end, we do the satisfaction survey to kind of see like what did everyone think? How did it go? And we're seeing about 100% of participants would recommend this training cohort experience. 100% rated the experience as satisfactory or very satisfactory. We had about 60% say that they would repeat it, meaning that they would like to come back and try this cohort experience again, which I thought was really encouraging because it is a 6-month commitment. And for a lot of folks, after you've engaged with this experience, which starts out as being pretty intensive, at first, and then we do taper off as we get, further into the 6-month experience where they're meeting less frequently and things like that. But these are weekly meetings. And so I was really encouraged to see that folks would be willing to invest their time into this experience moving forward. So really great feedback, like I said, overall. And we're taking all of this information and utilizing it for our planning for the next cohorts and for the next training season. But when we think about future directions and kind of where we want to go from here, one of the primary areas that we want to do is continue to adapt our processes. And the great thing about our program is that we are able to be responsive. And so that has been one feature that I've really loved about this program. The other piece is we want to maintain leadership buy-in and increase team member engagement. Like I mentioned before, we are making some small adaptations just based on trying to make sure that we're keeping the team engaged, like the overall larger team, just because we were seeing like with the virtual meetings, people were kind of like engagement was a little bit waning. And so we've been moving to like the hybrid and the in-person meetings and things like that. So we really want to just keep that engagement high, that interest level high, so that we can continue to see these really great outcomes. The other piece is the cohort model spread. So we're working on, like I mentioned before, we're going to launch 3 new cohorts starting in June. And we're going to try to do those more rolling. So whereas when we first started, we did like 1 cohort for the first training season, 1 cohort for the second training season. This next training season, we're rolling out 3 in June, and we're going to hopefully keep those rolling as we get through the next training season. And then, of course, we're also looking at a piece, and this was one that I found very interesting, and I really wanted to make sure that we were emphasizing because I think it would help to make my job a little bit easier, is our onboarding processes. So we're trying to work on making sure that we do some type of level setting as folks are coming into their roles, just based on the fact, too, that folks can be coming in at any different point in the training season, and so they may not have gotten the fall, curriculum of trainings, and they're coming in, kind of towards the middle or something. And so it's really been a challenge to try to make sure that we're meeting those needs and that folks are up to speed. And we have, all of these trainings are recorded and they can go back and view and, do the trainings in that way. But it's been a challenge to make sure that folks, at least as they're coming into the position, that they have the support that they need. So we're working on more of like a kickstart kind of program or a kickstart approach to really try to help to bolster our efforts from an onboarding perspective. And so we have our education specialists, both on the Healthvine care management side and on the higher rise care coordination side, that are really going to help us to, as folks are coming into their roles, support that piece of the onboarding. And so hopefully that, obviously I'll be engaged with that work as well, but we're hoping that that's something that our education specialists can really help to support. All right. Well, we are wrapping a little bit early. If you'd like to read and learn more about this area, definitely recommend kind of checking out some of the references we have there. One of the articles there, the one that starts with McClure, that's the one that we recently published around just specifically this approach. So if you'd like to learn more specifically about the population health efforts and the training program and other efforts that are taking place around the institution, that would be a great place to read and kind of get some more information regarding that. And then, thanks for your attention. If you have any questions, feel free. I'll just kind of hang out for a few minutes.
Thank you so much for an incredible presentation. We'll take questions from the room and from the chat. So anyone in the room want to start us off with questions?
Thank you so much. It's so exciting to see the work that you're doing and the ways that you support these folks. And, I love the slide with the sort of annual and the weekly and seeing the ways that you're really supporting their well-being, preventing burnout, making yourself available. Really cool. And just thinking about the resources across the continuum, across multiple institutions, right, that you're supporting those folks is really neat. One thing that I wondered about, and we wrestle with in our work, community health workers in particular, I think the scope of practice and their role in evidence-based care, the role in behavioral health is being ironed out, and there's different sort of lots of different considerations. I'm curious about how, what role do they take in behavioral health, in particular evidence-based practices? I don't know if you could give any examples of ways that they've been involved in care. Where that's something that we're actively thinking about out here.
We actually do have, so on our team of care management, or on the health and care management side, we do actually have community health workers who support the work that they do. And so most of our patients and families will have a primary care manager, and then the community health worker who also works alongside that CM. And so for this, actually the most recent cohort that we did, we were able to incorporate them into our cohort experience. And I will tell you, it's interesting to get the different perspectives and to learn, much like what you're referencing, which is that overall scope of their training and education and the practice there. But I will say, having them all kind of come together in a training experience where they can really glean a lot from each other. I think their knowledge of the case and their contact with the families and their engagement with the families is so informative when we think about those issues that sometimes, if you're more operating from a coordination standpoint of trying to organize and get everything, together and trying to think about it from an overarching perspective. But our community health workers are on the ground. They're going oftentimes out into the community. They're seeing the homes. They're seeing the places where folks are, living and dwelling. And so I think they have a level of knowledge and expertise that we can leverage, although it may not necessarily be specific to these advanced or really, critical clinical skills, but I think the pairing works really well when we think about how that works in the cohort setting, because I feel like they learn a lot, but they also are able to contribute a lot from their perspective. And so like I said, when we're creating this learning group, we really were considering a lot of those things, which is, what do you bring in and what can you offer that will benefit the overall group? And so I didn't see any significant issues with, those two groups training together, if that makes sense, and being able to kind of try to help to level set a little bit. I think it was more of just a really good experience, because our more seasoned, experienced folks who have a little bit more exposure and background in the area were able to provide that, kind of concrete, knowledge and their expertise. And then for our folks who have more of the on the ground experience, they were able to offer those insights and those perspectives, which I thought were really meaningful. So.
Thank you so much. This is really exciting. I was impressed, 18 months ago learning about this, but your numbers are just so impressive, even more impressive now. I was curious about just kind of the institutional resource that it takes to do something like this. I mean, now you have the data that speaks for itself, that this was so worth it, whatever resource that was put in when you look at the patient engagement rates and the ED visits and things like that. I'm curious I know this is specific, so it's okay if you have to just broadly give an estimate, but about how much time are your cohort members spending per week in not the clinical care, but the cohort training experience and the office hours and the drop-ins and all of that? And what was the process of getting the institutional resource or buy-in before you had the outcomes to prove how valuable? I was curious if it was grant funded or if it was an investment that was made by the healthcare system.
Yeah, so HealthVine is sourced by a couple different things. So we do have institutional support financially. And so there is a kind of a line in the budget that helps to support us that way. Most of the funding, though, is coming from the state. So we do get, based on like the Ohio Rise programming and things like that, we get a significant contribution that way. And then just mainly because we're serving that Medicaid population of youth, that is, we get a lot of funding that way as well. So we kind of coming in, we were well resourced to do the work that we need. We basically had to make sure that we were putting the right people in the right places to be able to, one, from a leadership perspective, perspective, advocate for and make sure that we stay in the, sight lines of those folks who are the decision makers and can, help to sustain our programming, but also, all the way down to the folks who are going to be, like myself, actually delivering the programming and things like that. So, like I said, it goes back to that, making sure that we have the right people in the right place. I think when it comes to the commitment that our cohort members are making, the office hours are still optional. So they don't necessarily have to attend every single office hour, but really their commitment to me is that 6 months of the weekly meetings. And those meetings, we typically try to, get all of that condensed down into like a 50 to 60 minute meeting. And they meet with me weekly and we walk through all of that. And so while it seems like there's a lot of moving parts, a lot of things going on, we kind of have this universal track, which all the team is moving through. And then the cohort experience really is about an hour of their time that's dedicated to that. They also we've been able to work with our leadership team, though, to negotiate where they get some protected time to prepare their case presentations and things like that and to attend the meetings. And so they don't get like docked if they're in the meetings or, having to spend some time putting together their case presentation. So we've been able to kind of work through that with the teams, and that's made it a little bit easier for folks to participate and not feel like it's a little bit overwhelming or like it's a lot to commit to.
We've got some questions in the chat here that I'll read out. First, thank you for an excellent presentation. One of our audience members actually worked at Cincinnati Children's in the 1980s. And the question was, if you could summarize some of the key competencies connected to training and education that you're hoping to see for the care coordinators or care management folks.
Mm-hmm.
I think just adding this question just a little bit, also what you were mentioning there, your funding sources, if any of those key competencies are things that help connect you to funding by making sure that folks are meeting competencies for their professions.
Got it. Yeah. So we don't right now, there's not necessarily a connection to funding for that. The institution as a whole is moving to, value-based care and things like that. But specifically for my teams, I mean, they can use that information on their, their evaluations at the end of the year, performance evaluations and things, but there's not like a specific connection between that. Some of the core competency areas, though, that we definitely are emphasizing are trauma-informed care, person-centered care, motivational interviewing. We're looking at making sure they have clinical skills. So things like being able to do some type of case conceptualization, being able to identify those common childhood disorders, do some crisis, intervention and things like that. We're working on obviously the cultural competency piece and making sure that they have the skills to work with groups from very diverse backgrounds. We're also working with our teams around the area of burnout mitigation. That's a big focus for us as well, to make sure that they can, stay in their positions and feel that they are, that their well-being is not being sacrificed in pursuit of this work. So when we think about like those kind of core areas, those are really the areas that we are working hard to make sure that we have supports in place for and that we're highlighting with regard to our trainings. And you'll find that like all of our trainings fall into one of those buckets. Like they're gonna kind of come across but we'll do different angles at it. So like if we're doing trauma-informed care, 1 year we might do those basic core principles of trauma-informed care. 1 year we did specifically focused around children who've experienced child abuse or neglect and things like that. And even for our cultural competency topics, we're looking at things like, inclusive language and how do you best support, or operate from a perspective of cultural humility and things like that. So while we have the broader topics, we can certainly, pick out and select, specific things to target with regard to what we're training under those kind of larger topic areas.
And then we had another question around funding, which I think you've addressed a bit, but I just wanted to call out one other additional piece in this question. Kathy Brewer is saying this is such an amazing program. I think we all agree. For mental health workforce, can you share how it's funded, which you did a little bit. One of the points of her question, though, was what helps you get funding approval from leadership? And I'm wondering, what are the points that really resonate? What have you found to be really helpful in advocating for this program and helping folks recognize just how valuable it is for the people that are involved in it and for the community.
Yeah, well, outcomes help. Good outcomes help. I think the other piece, though, is just like I said, the level of buy-in. And I think when we were, we're looking at the leadership, even the leadership teams, like if you think about mid-level management within Healthvine, the leadership team that was selected to, CEO and head up Healthvine and things like that, as this entire entity is being developed, they are making sure that they are investing in and hiring people who are invested in this process. And so when we think about then taking that to the institutional level, many of these folks who are in our positions of leadership have those broad reaching connections. And we think about Jessica McClure, who is, who I report to. She is our now Associate Chief of Population Health. She is in a position where she can give ear to, the work that we're doing and keep it, acknowledged and recognized within the institution. And so a lot of the work that we have done is around just trying to help to make sure that people are aware of the work that we're doing, that they see the outcomes that we're getting. So we're in the newsletters, on the, the websites and the pages, any kind of information that's going out to at the institutional level that that we know is going to highlight some of the really great work that we're doing. We're trying to make sure that that stays out there, and it helps to have people who are kind of in the rooms and in the spaces where decisions are being made, and that we keep this in front of people, basically. So that's really been, I think, a really beneficial aspect of the programming. And like I said, me on my end of the spectrum, I'm not so much in those rooms, but for me, it's just making sure that the programming is solid and that we're being responsive. And I think that the teams themselves, mentioned voice of the customer, that speaks very loudly. And so I think if people are saying, hey, we love this is great, this is really helping to support our teams, this is really critical to the work that we're doing, it's kind of hard to ignore those voices. So it's really just overall, I think, a team effort, but also I think it helps to have people who are positioned where they can really give voice to the work that we're doing and keep it at the notice level.
Thank you. Another question from the chat. Thank you for this fantastic work. Wondering if you could speak to any other variables you were able to identify that made a big difference in terms of helping service delivery staff increase their buy-in and commitment and engagement to training and consultation. Any other ideas that help balance their time between service delivery, day-to-day work versus consultation, training, office hours?
Mm-hmm. So that's an ongoing struggle. We are definitely working on increasing team member engagement. Like I said, office hours can be hit or miss, and so the degree to which people are able to engage. So we've really worked hard to try to find times during the day. Like if we're offering, afternoon on one day, we're going to try to offer some mornings, different days, and just, because sometimes it's more of a logistical, they have meetings with family scheduled, their days are very busy. And so it's just hard to carve out the time for this additional work, which, for the most part, they're able to get CEs for all of the trainings. And so I think that goes over really well with the team. So that kind of motivates them to, and incentivizes them to stay engaged with the training program. But I think the other piece is just making sure that we are kind of fitting the program into their day, so that it's usually, if we're going to offer training, it's during a time when we know that most folks are going to be able to make it. Also because it is mandatory, so they have to make it. But also we are trying to offer the office hours during times when we know that the teams likely will have the most availability. And so we're able to kind of move things around to ensure that it's as easy as possible to engage. And then we just hope that the value of the programming is what motivates people to stay, continuously engaged with the program. But that's been something we've been working through on an ongoing basis. It's just, how do we best do this ongoing training in a way that doesn't, interfere with or impede the work that they're already doing or feel overwhelming, with everything else they have going on. But the great thing is, in my role, I'm a little bit on the ground, and so I can really see, I know the teams have this coming up. They have this other training thing they have to do based on, our nurses are going to be doing this next week, and they got this that week. And so we can really schedule things, and move things around to really best meet the needs of the team. And so that tailored support, I think, is one of the biggest pieces that helps it to be sustainable.
Thank you. I'm going to be kind of selfish and ask one of my questions as the last one that
No,
we'll
go ahead.
do this morning. But kind of on the same lines, you mentioned self-directed trainings, and I think something our team has been thinking a lot about is kind of adult learning theory and how professionals engage in training kind of as a as needed information gathering. And I'm wondering if you're tracking engagement with any of those self-directed materials, and if you're seeing folks going and getting information kind of at the moment they need it, or kind of the balance between kind of the more structured cohort model versus getting folks information that's really relevant to maybe the patient they're seeing next.
Yes. So that has been something we've been really thinking about how we can best support with. One of the things that we're trying is we have a training library, which is, all the teams have access to. And so all of my training materials and things like that go into the training library, but folks are also able to go in, and we have different folks, our leadership team, they will provide resources and things like that. And so it's kind of a centralized location where if you are looking for more self-directed learning, research articles, information, you can kind of get that in that place. And when it comes to the actual training experiences, those are on demand. So if we identify a need, or if the leadership team identifies a need, then we will pull those together. We call it rapid development, and we will roll it out to the team. And so that is, I think, one of the key ways that we're able to kind of keep the training and the experience more self-directed. And like I said, we schedule it when it's most convenient for them to be able to engage with that training. And we create those opportunities. If there's an interest, we try to create an opportunity for that to happen. And the great thing is, in my role, I know many providers, much like myself, are both doing this type of work and still in clinical practice. I have the privilege of not having to be engaged with patients in a clinical practice setting. And so this is my full-time 100% role. And so I'm able to really be flexible in how I'm able to offer that. And so I know that flexibility is not something that maybe a lot of folks have. But for me, this has been a really great experience in that I can tailor it, as much as we need to meet the needs of the team.
Thank you so much. It really reflects that balance of nimbleness and structure that you were talking about, and something for us all to aspire to in creating programs that meet community needs. So thank you so much. A resounding thank you for an incredible presentation and really helpful consultation for us all here at the end as well.